Hello, doctors. I'm Dr. Chris Rapoff of EZQME Continuing Education, and welcome to this week's presentation. Today, I'd like to discuss a condition of the knee that is not extremely rare, but is often underdiagnosed due to the similarity to other causes of knee pain, and it's called Hoffa's fat pad syndrome, also known as infrapatellar fat pad impingement. Now, clinically, it's a condition that's characterized by an inflammation or an irritation of the infrapatellar fat pad located beneath the patella. This syndrome can also result in significant anterior knee pain and functional limitations, often affecting individuals with repetitive knee stress. For instance, an examinee with knee pain as part of a cumulative trauma injury, or an athlete. So today I'll provide some clinical insights and clinical characteristics that are necessary to have a firm grasp before finalizing a diagnosis of Hoffa's syndrome in an examinee. Okay, let's get started. First, these are the following sources that I referenced when producing the presentation for Hoffa's syndrome. I encourage you to explore these references if you'd like a more in-depth understanding of our discussion today. This syndrome was actually named after Albert Hoffa, a physician who first described this condition in 1904. So, getting into this condition here, the infrapatellar fat pad we know is a soft, fatty tissue that is situated beneath the patella and behind the patellar tendon, as you see in the diagram below. It does serve as a cushion to reduce the friction between the patella, the femur, and the tibia during knee movement. Now, this structure is highly vascularized and innervated, making it very sensitive to trauma and inflammation. Some of the causes and risks of this condition can include from many different factors. However, some of the more common factors are repetitive trauma. And those would be the activities that involve frequent knee hyperextension, such as jumping sports. Also, direct trauma, a blunt trauma to the anterior knee, or a biomechanical abnormality. Conditions like genu recurvatum increases susceptibility of this condition. And also post-surgical changes. Any alterations in the knee mechanics following surgery may contribute to this type of impingement. Some symptoms of Hoffa's syndrome can include a sharp pain in the anterior knee, especially during movement, swelling and tenderness around the patella, difficulty fully straightening or bending the knee, pain exacerbated by prolonged standing or walking, or it can be exacerbated by a prolonged standing, walking, or activities that involve repetitive knee movements, like jumping, for instance. Diagnosing this condition involves a combination of clinical examination and of imaging. In the clinical exam, palpation for tenderness and assessment of ranges of motion of the involved knee would be involved here, and imaging. MRI is the gold standard for identifying inflammation or impingement, while X-rays help rule out other conditions of the knee. Treatment options available involve a conservative treatment and a more invasive treatment. First of all, conservative treatment would exist with rest, ice, anti-inflammatory medications such as NSAIDs. In addition, physical therapy focusing on strengthening and flexibility in the knee, and surgical intervention if the condition becomes so chronic that nothing else is helping. They would suggest arthroscopic resection in severe cases to relieve the impingement and restore function. Prognosis and prevention of Hoffa's syndrome? Well, with timely intervention, most patients really do fully recover. So preventive measures include avoid repetitive knee hyperextension and strengthening the surrounding muscles to support the knee joint. Now, you may be asking yourself, well, what's the difference between Hoffa's fat pad syndrome and patellofemoral pain syndrome that we many times encounter in our QME examinees? Well, here is the differences between the two as a comparison. First, in Hoffa's syndrome, the cause, we know, is an impingement of the infrapatellar fat pad, often due to repetitive trauma, hyperextension, or direct injury. Whereas in patellofemoral pain syndrome, the cause would be an overuse or a biomechanical issue leading to an irritation of the cartilage, not the fat pad, or the structures around the patella. In Hoffa's syndrome, the pain location is a pretty sharp, localized pain beneath the patella at the infrapatellar fat pad that's often exacerbated by full knee extension or prolonged standing. In patellofemoral pain syndrome, we have a diffuse pain around or behind the patella that is often worsened by activities like squatting, climbing stairs, or sitting for long periods of time. Now, the symptoms in Hoffa's syndrome would include swelling, tenderness around the fat pad, and difficulty fully strengthening the knee. In patellofemoral pain syndrome, we have the symptoms of aching pain, crepitus, and occasional swelling. Hoffa's syndrome is highly diagnosed by the MRI as the gold standard for identifying the inflammation or impingement, whereas patellofemoral pain syndrome is more of a clinical examination focusing on patellar tracking and alignment, and imaging is really less commonly required for that diagnosis. And finally, in Hoffa's syndrome, rest, ice, anti-inflammatory medications, physical therapy, and in severe cases, arthroscopic surgery would be involved. In patellofemoral pain syndrome, treatments would involve strengthening exercises for the quadriceps and the hip muscles, activity modification, and addressing the biomechanical issues. Now, as you see, although both of these conditions do cause knee pain, there are some similarities in these two, but there are some very distinct differences that set these two syndromes apart. So in closing, Hoffa's fat pad syndrome is a condition that demands attention, not only for its impact on the knee function, but also for its potential to be overlooked in a clinical setting. As we've seen, early diagnosis and appropriate management, whether through conservative measures or surgical intervention, are crucial to restoring the mobility and preventing chronic discomfort in the examinee or the patient. So by understanding its causes, symptoms, and treatments, as well as adaptive preventive strategies, individuals can reduce the likelihood of recurrence and maintain an active, pain-free lifestyle after the fact. Hello, doctors. I'm Dr. Chris Rapoff, and again, I wanted to thank you for taking the time to join me in today's presentation. I hope you did enjoy it, and I look forward to sharing other interesting subjects as they relate to the workers' compensation system in the state of California. Until next time, thank you.